So we did a study looking at real-world outcomes for patients with CLL, treatment naive, who are high risk and got either ibrutinib versus chemoimmunotherapy. This study is important because we know repeatedly in clinical trials it's been shown that in the treatment naive and relapse refractory setting, patients with CLL don't do as well when treated with chemoimmunotherapy compared to targeted therapy if they have high-risk disease. So we did a chart review study of 516 patients with CLL treated at either community or academic centers. About 2/3 were community centers, about 1/3 were academics, 40 clinical sites in the United States. And we defined high risk as patients having either 17p or 11q deletion by FISH, a mutated p53 status by sequencing, and an unmutated immunoglobulin heavy chain. If patients had cytogenetics checked and had 3 or more abnormalities, those patients were also included as high risk. To be non-high risk, patients had to have FISH, p53 mutation, and immunoglobulin gene rearrangement testing performed, and no high-risk features identified. So if patients had incomplete testing, those patients had to be excluded because we couldn't confirm they were non-high risk. So overall, we identified 271 patients with high-risk CLL, of which 175 were treated with ibrutinib and 96 were treated with chemoimmunotherapy. And our goal was to determine how these patients did with time. So as a surrogate for progression-free survival, we used time to next treatment, and we also used the percentage of patients requiring only 1 line of therapy during the study period. So we found that, in the real world, patients' treatment is not usually assigned randomly. So we did perform inverse probability treatment weighting in the high-risk groups to balance baseline characteristics while preserving and balancing sample size. So we found that of those patients with high-risk CLL, those treated with ibrutinib had a longer time to next treatment compared to chemoimmunotherapy, so not reached in the ibrutinib group versus 34 months median time to next treatment in chemoimmunotherapy. And we also found that there was a higher percentage of patients in the ibrutinib group that only required 1 line of therapy during the study period. So 1 line of therapy was needed in 74% of patients treated with ibrutinib, compared to only 47% with CIT, and the remainder of those chemoimmunotherapy patients did go on to second-line treatment during the study period. We also performed some inter-treatment comparisons. However, due to the fact that baseline differences can reflect inherent differences associated with risk, we did not perform weighting. And we found that the use of ibrutinib, at least in some ways, seems to neutralize partially the high-risk features of having, abnormality by FISH or p53 mutated or unmutated IgVH, because the time to next treatment and percentage of patients requiring only 1 line of therapy was similar in high-risk and non-high-risk CLL if treated with ibrutinib. We saw in the chemoimmunotherapy group that the time to next treatment was significantly shorter in patients with high-risk CLL, and there was fewer patients who required only 1 line of therapy. So those patients did not do as well as the non-high-risk CLL if treated with chemoimmunotherapy. So importantly, this real-world study highlights the need to check for high-risk features, particularly in the upfront or relapse refractory setting, if patients are being considered for treatment with chemoimmunotherapy. Because we know patients don't do as well with chemoimmunotherapy if they have high-risk CLL, and the standard of care, as highlighted in IWCL and NCCN, among other guidelines, is to use targeted therapy, such as ibrutinib or others, for patients that have high-risk CLL.